Now we start firstly with counseling. I start from counseling because many people confuse and mix the concepts and different areas and strategies of counseling and psychotherapies with each other. So, yeah. What is the counseling? Counseling is a series of contacts with the individuals which aims to offer him assistance in changing his attitudes and behavior. Here is more need to focus on basic counseling skills, because in the next slide I want to share with you the CBT basic techniques in group sessions, especially we used in group sessions and experimental groups. Basic counseling skills are reflecting and paraphrasing, summarizing, attending, silence, rapport building, focusing, and questions. These are the basic counseling skills, are the basic characteristics in a counselor. Here is many other strategies of counseling that we can use with the patients, with the almost mild to moderate level of patients in initial sessions. And we also used these strategies in our first and second sessions. And then we move on our CBT, our therapeutic module. So here is what is CBT? Cognitive behavior therapy is a psychosocial intervention that aims to improve mental health. CBT focuses on challenging and changing cognitive distortions and behaviors, improving emotional regulations, and the development of personal coping strategies that target solving current problems. Okay. I want to share a video with all of you, and then I will share all these strategies of CBT with you. Sorry.
Making sense of CBT, a guide to what CBT is and how you can decide whether it's best for you. If you're living with a mental health problem, it can be
Tanya, we can't see the video.
Okay, ma'am, I share with this video with you.
Oh, okay. Is the video in separate file?
Yeah, ma'am.
So I think you need to stop this
Okay.
and then play the video.
CBT is and how you can decide whether it's best for you.
Ma'am, now you can watch?
Yeah, we can watch now.
Okay.
If you're living with a mental health problem, it can be hard to know which way to turn or what to do to feel better. You might go to your GP, and one of the first things they might offer is CBT, which stands for Cognitive Behavioral Therapy. It combines cognitive therapy, examining the things you think, and behavioral therapy, examining the things you do. The word therapy might make you think of laying on a couch talking to a man with spectacles and a beard about your childhood while he analyzes your dreams. But CBT is actually a very practical type of talking therapy, which focuses on goals and focuses mostly on the present day and things that are affecting you in your life now. The theory behind CBT is that the way we think about situations can affect the way we feel and behave. It does this by dealing with how your thoughts affect your feelings and behaviors, and teaches you coping skills for dealing with different problems. For example, you might make a simple mistake, like, say, burning the dinner. This might make you think bad things, and it might make you feel worthless and inadequate, which which could lead you to do things like withdrawing, snapping at your family, or trying to avoid things which you think might go wrong. Or perhaps you've been invited out for drinks with some friends, and you start thinking negative things. This might make you feel anxious and scared, which might make you do something like saying no to the invite, avoiding your friends completely, or using drink and drugs to cope with the situation. Over time, whether it's years, weeks, or months, this cycle of thoughts, feelings, and behaviors may have happened so many times it's become like a habit. You start avoiding situations more and more, or automatically blame yourself if something goes wrong. And the more you do these things, the worse it can get. A CBT therapist will help you break this cycle and figure out what sorts of negative feelings, thoughts, and behaviors might be contributing to the problems you're experiencing. They will help you deal with your negative thinking and help you change your behavior, both of which will lead to an improvement in your mood. CBT can be helpful for people with nearly every diagnosis you can think of and can be delivered through one-on-one sessions, in groups, self-help books, online, or through a CD-ROM. That doesn't mean that CBT works for everyone, though. Some people struggle with it because they find it just too hard to talk about their feelings. CBT is usually quite a short-term treatment, and so you may find that your problems are too complex to deal with in the time. It can also be quite hard work. Your therapist will probably set you homework, and you have to really practice the skills they teach you to see a difference in how you're feeling. If you don't think CBT is the right treatment for you, you should be able to talk to your GP about what alternatives there are. The Mind website also...
Okay. I shared this video because, as ma'am said, many students who having not any psychology background, and that's why I put this video here for your understanding about CBT, what is cognitive behavior therapy and how it work, and how a cognitive behavior therapist work with patients of different psychological disorders who are suffering from different psychological disorders. And in that video, one second. In that video, they told us about when we think and then we behave and then we feel like that. Okay, here is another video I conducted with my students. I shared that video to all of you. Here is some problems to sharing this video. I want to share because in
Tania, you need to open first. You need to open first, then only you share. Stop sharing.
okay.
Okay, now open first in your laptop.
I want to share this video because as we watched in the previous video, what is cognitive behavior therapy, and we give a rationale to the patients when we psychoeducate about his or her disease. What is negative automatic thoughts, how we feel about these thoughts, and how we act and behave negatively, and why we can't control all these negative automatic thoughts. In this video I share all the answers and response of all these queries, and now I play this video. And just focus on the word. Imagine an iron on your right hand. Now imagine a magnet the left hand. Concentrate. Just focus. You can feel more. Open your eyes. Don't move your head. Okay. Now feel relaxed. Take a deep breath. Now just tell me what you feel. Okay, you feel an iron as well. Do you feel some attraction between your hands? Close to each other. Okay. As said earlier in your session, you said that I have some negative thoughts, but I don't have any type of control. Can't control my thoughts. Can't control my feelings. Okay. But now, here is the main thing which that so you feel an iron and you feel a magnet, but in reality, you don't have these two things. You think and you just imagine, and then you feel like that here are these two elements in your hand and they attract to each other. Okay? When you start this exercise, your hands on, but then you end this exercise, your hands are these. You guys exercise? Okay. So, this is the most important thing that whenever you command your mind and your brain, okay, but any type of command that you give your mind or brain, your mind and brain like that. So, if you give positive commands to your mind and brain, behave like a positive man. But when you give a negative command to your mind and brain, then you behave like a negative person. Mind and brain all instructions. Mind and brain function like all circuits. Okay, but for that, we can perform our all actions and we can perform according to our mind, instructions, and brain. Here are the main two things: mind follow all instructions. Okay, we not function according to our mind. Our mind function according to ourselves. Okay. So, ma'am, here is the main concept about the mind and behavior and the commands which we give to our mind. So, I want
Right.
to ask the students who watch this video, can they get the understanding and point about CBT?
Mm-hmm. Okay. Asking the class, right?
Yeah.
Okay. Can you explain, first of all, about the activity that, you ask that your client to raise her hand up and
Yeah, sure, ma'am. Ma'am, this is the main activity we use with all the psychological patients, and it's
uh-huh.
very effective because they always said we have negative thoughts, we feel like we are lonely, we are worthless, but we can't control all these thoughts. So we use this strategy. Basically, it's the technique of hypnosis, hypnotherapy. This
Okay.
is a small strategy of hypnosis, but we can use with all the patients to give them rational about irrational thoughts.
Mm-hmm.
Okay. And we psychoeducate that it's all about your negative automatic thoughts. In reality, these thoughts have not any rational with reality, and it's all because of your negative command to give your to give your mind and your brain, and then you feel like that. So here is need to
Okay, by
change.
just doing that.
Yeah, so here is need to change. Firstly, we write all these thoughts of patient. Even I share the DTR chart in my one of my video, and I don't know you share with your students or not, but they can
Yeah,
see.
I shared some of them watched the videos. I'll pause them not to ask a question in the beginning.
Okay.
So otherwise they really in queue to ask you many questions.
Oh, okay. So, when we practice this exercise with patients, we start this strategy in initial sessions. Mostly we used in our second or third session. But before the practicing this strategy, we give a DTR chart, dysfunctional thought record chart, to the patient in first session as a homework assignment, and then he or she complete this chart in the second session. Then we practice this exercise with patient. And it ma'am, can you watch my slides?
Yeah, I can see.
Okay. So here is I mentioned some strategies of cognitive behavior therapy, and all these strategies basically we use in under the cognitive restructuring of cognitive behavior therapy. So firstly, I want to share that cognitive restructuring is the basic technique of CBT, and all these strategies of cognitive restructuring. You can also perceive that all these strategies are all these types of cognitive restructuring, and we use all these with the patient in initial sessions, and when we completed all these tasks step by step, then we move on our therapy. We can't give direct therapy to the patient, so that's why here is I mentioned DTR chart, and as already I said that I mentioned this in our one of our video. DTR chart basically it used for to identify the bad event of the patient, and when that event will was happened, and what are the negative automatic thoughts associated with that event, and how patient feel when he think about that event, bad event, and how he what type of emotions he has. And then we ask them to when he write negative automatic thoughts, try to convert into a positive or alternative thoughts. And if he try to convert positive thoughts or alternative thoughts, what are the outcome of his alternative thoughts? And if he didn't convert or transfer his negative thoughts into a positive one or alternative thoughts, then what are the outcomes of his negative automatic thoughts? So here is also we can use uh, cost and benefit analysis with DTR chart. Vicious cycle, it's also used in the first two sessions for psychoeducation purpose, and I also mentioned and discuss in my videos. When we use baseline chart basically we use with the patients as a homework assignment, that in the previous week what would was happened, and then he write his emotions, feelings, and he also rated his emotions and feelings with that event, and how he solved he solved his problems his own self. And after that we use double column technique and triple column technique. These are also basic CBT techniques we used under the cognitive restructuring, but these are also the basic techniques of CBT. In triple column, we draw three columns. In the first column, we ask patient to write his bad event, and in the third column, we can't fill the second column in the same session. Then we ask patient to the third column. In first column, he wrote about his negative bad event, and in the third column, he wrote his negative automatic thoughts. And when he completed this task, then the therapist fill the second column, cognitive distortions. The therapist used cognitive distortions according to his or her negative automatic thoughts, and use cognitive distortions because on the basis of his or her cognitive distortions he give counseling and give rational to his irrational thoughts. So here is behavior monitoring chart. Behavior monitoring chart is the same like baseline chart. We used baseline chart for one event, but we used behavior monitoring chart for multiple events. Then we give activity schedule as mentioned in the first video when I played about the CBT. They also told about activity schedule and daily task checklist. We give these things to patients only because of to engage the patients and make busy routine of his or her, because when the patient is free, he she always think negatively and always make nonsense things, and that and finally at the end they move on for suicide. They have suicidal thoughts, and then they feel like more irrational thoughts, then they try to attempt or committed suicide. So when we completed all these things in our first, second, third, and fourth sessions, then we start therapy, cognitive behavior therapy. What is cognitive behavior therapy? What type of CBT we use? We used detached mindfulness, But before detached mindfulness, we used relaxation, some relaxation and meditation exercises such as guided imagery, like PMR or deep breathing, and we also mentioned and discussed all these relaxation and meditation exercises in our recorded sessions video. You all can watch, and then if you have any query, you can ask freely to Ma'am Sarla. So when we practicing some relaxation exercises, and then we move on or detached mindfulness. We use detached mindfulness in the third last session. And what is detached mindfulness? I give you overall background about this strategy. It's basically we can call CBTs. When we said therapy, we talk about detached mindfulness. And I focus on detached mindfulness because my PhD thesis is also based on this therapy, and it's really, really effective. Initially, this therapy used with OCD patients, obsessive compulsive disorder patients in all over the world, but in some recent researches, it's also effective with major depressive disorder. And I received many good feedback and many good responses from the patients in my personal clinical private clinical setting, and that's why I want to introduce this technique through my PhD research. When I completed this therapy with patients, then at the end of the session, in the last sessions, we used relapse prevention and therapy blueprint. In relapse prevention, we use relapse prevention because many patients, psychological patients, uh, have multiple relapses. They take therapy, they take counseling for their problems and issues, and when they completed their sessions after 1 or 2 years, they experience again a trauma or a bad event, and then they feel all the same feelings and emotions and behaviors, and they involve in relapse. So here is highly need to give a relapse prevention very well. The main rationale of this strategy to prevent relapse of your patients. And in last, we use therapy blueprint. Therapy blueprint, we asked some questions from our patients, that such as we asked how you what type of things or strategies you learn from your all sessions. If you feel uncomfortable, or if you feel sad, or if you feel lonely, then who are the three persons you share your all problems firstly? And then we ask that if you try to solve your issues or problems through all these strategies which you learned in our sessions, then what are the outcomes of this? And if you can't use all these strategies and can't try to move on in your life, then what are the outcomes of that things? So we used therapy blueprint worksheet and relapse prevention worksheet with the patients. I give the concepts about all these things uh, only for your understanding, that how CBT work with psychological patients. And these are only some small type of strategies. We use some basic techniques of CBT, and even we can use some techniques of others therapies. We use all our psychotherapies such as REBT, such as drug addiction therapy, such as DBT, dialectic behavior therapy, according to the patient, according to their severity level. So, but we focus on CBT because we want to share the CBT and counseling therapeutic module for your understanding. Firstly, I want to share here counseling module. I share counseling module because I want that you must have to know about the counseling module and therapeutic module for your better understanding. In counseling module, we plan here, I mentioned 15 sessions, but we can plan 13, 14, 12 according to our problem statement. In group sessions, you can see here in session 1, we introduce trainers to trainees and vice versa. In session 2, created goals and objectives of the group. In session 3, transferring techniques to help participants express feelings of love. In sessions 4, transferring technique to help participants differ the feelings of hates. Then we use counter transferring technique in 5 and 6 sessions to facilitate the feeling of love and hates. In session 8, 7 and 8, free associate to express any of their feelings in the group. You can also relate all these things with different theories, especially you can relate this Carl Rogers theory. In session 9 and 10, resistance to identify a client who do not share anything and help them to talk. Session 11 and 12, gratitude to make the client understand and appreciate. In session 3, summary about the previous sessions. In session 14, closing of the intervention. And in session 15, farewell party, friendly match among inmates. So you can read all these strategies, all these techniques of counseling module. I share these things here because firstly in this lecture I said that many people mix the concept of counseling and therapy, especially when they used our module in groups. So I share this because you can easily differentiate between these things. You can see counseling techniques here, and now I want to share a CBT therapeutic module. You can differentiate all these things and write some points about both therapeutic modules. In CBT therapeutic module, I make only CBT therapeutic module. It's not psychotherapy or therapeutic module because many students, I don't know about the Malaysian students, but in Pakistan, many students mix the concept of CBT and psychotherapy. They said the CBT and psychotherapies are the same things. These are not the same things. CBT is only one therapy. Psychotherapy means group and set of therapies, set of different therapies. So CBT therapeutic module in session 1, we work on rapport building, history taking, MSE, mental status examination, visual analog. It's a Likert scale when we use for pre and post assessment rating of symptoms. Homework, DTR, visual analog and DTR, dysfunctional thought record chart, we used in our second and third sessions, and I mentioned and discussed in our videos. In session 2, review of homework, our first session, formal assessment if we need. Formal assessment, I mentioned BDI because because this is the therapeutic module of my PhD thesis, because I worked on major females with major depressive disorder, and I make CBT therapeutic module, and I prepare some sessions for collecting data of my PhD. So I mentioned here formal assessment BDI2 because I work on major depression and we assess the severity level of depression through Beck depression inventory for finalizing diagnosis, and then after diagnosis we can give psychoeducation to the patient. I also discussed in detail about psychoeducation in my recorded sessions video. Session 3, introducing members, goals of sessions, explain intervention plan, detached mindfulness based on CBT. I mentioned detached mindfulness in the third session because, as already I told you, this is the therapeutic module of my PhD thesis. So I mentioned this name only for the understanding or we can give concept to the patient about this therapy overall, and we can give brochure and homework practices related these things. In session 4, discussion of homework for prior session, training of cognitive restructuring as we discussed in the previous slide, and mindfulness practices awareness such as guided imagery and meditation, and its application, and brochure and homework practices. And brochure and homework practices, we give some worksheets to the patients for their homework assignments. In session 5, review homework for prior sessions, problem solving method strategy, explaining the logic of problem solving method strategy and its application. Problem solving method strategy is the basic technique of CBT which we used with the different psychological patients. In session 6, discussion of homework of prior sessions, training of CBT guidance, and association techniques of detached attention. Detached attention here is distraction. Okay, when a patient reported that he or she feel anxious, worry, sad, and a lot of negative automatic thoughts, then we guide them about detached attention or distraction. We ask them to distract his or herself when he or she feel like this. Aware, but it's a temporary treatment. It's a temporary. We used in initial sessions, but at the end we use detached mindfulness for their permanent treatment. Awareness and its application, brochure and homework practices. In session 5, discussion of homework of prior sessions, training of CBT guidance and association techniques of detached attention, awareness and its application. In session 8, discussion of homework of prior sessions, training of the train station, and imagery of passing cloud techniques of detached attention. Cloud technique is the main strategy of the detached mindfulness. We use this when we use therapy. In our therapy we use this technique. I can't share in details because it's really on a broad level, and uh, must have a one session for only for this technique. So that's why I give you overall concept about all these things for your group understanding about your group sessions in experimental research. In session 9, discussion of homework prior to sessions, training of imagination and looking at the thoughts, using techniques of detached attention and awareness. We also use here, I didn't mention here, but we also used the evidence-based some strategies with the patient, such as we used a worksheet with patient, evidence against and evidence in favor. We used this worksheet with the patients when he or she has a multiple negative automatic thoughts, and then we asked patient that what is the evidence about your negative automatic thoughts, please write down in the list, and what are the some evidences what are the some evidence which favor your negative automatic thoughts. Give us some rational and give us some evidences about your negative automatic thoughts, and then the client write in favor and against about negative automatic thoughts. Then we give counseling according to their suggestions. In session 8, discussion of homework upright session and relapse prevention management. Session 11, relapse prevention is the most important part of every therapeutic module. Session 11, discussion of homework for pride session, therapy blueprint and guide about follow-up. In session 12, discussions of homework of pride session, summarizing and answer the final questions of the patients. So it is the basic therapeutic module which we used with the patients. I mentioned in the last slide some activities about role play videos, discussions about role play videos and question and answer, but um I started in the first and second slide, so I don't need here is need to share again. You can watch because the videos are too long and it's not possible to share here. So it's all about from my side, and now, ma'am, it's your platform.
Okay, all right. Now, any question? We start with the questions.
Okay.
Uh, we start some of us already watched the video. We want to ask some questions to Tania. There were good concept use homework, homework. So that's what I said. When time goes, when you're doing an even individual or group session, you give some homework. So the homework can be very systematic, like according to Tania, because she's using her own module and also sessions. Some we can do it there and then, some we can send it back to the home to see whether the client is really committed or not. And one, to see the commitment. Secondly, to make the client remember the session. Because most of the time, as I told you all, it's good for us to do 2 weeks once, right? Because once in a week is too early. It's kind of too rushing. 2 weeks once is just nice. Once in a month are going to be too long. Client will have high tendency to forget whatever we have discussed. But in a clinical setting, sometimes, if they need to go for like depression cases, they need to go for a very short round table discussions, like once in a week. Depend on their how serious is the depression level. Like how Tania had been sharing, we use for depression, we use BDI, back depression inventory, and even in back depression inventory, we have inventory that for major depression, inventory for schizophrenia. They had divided. Okay, all the while I have been giving the class to use as a very basic depression that we wanted to see whether we are in a, it's not so depressed, but in a stress plus little high, something like burnout. If we are really in depressed, then we are supposed to go and see clinical psychologists or a psychiatric who can prescribe medication for us. If we don't treat that level, that depression level, then it will lead us to schizophrenia, multiple personality disorder, split personality. Very simple how to know what level we are. If we started hearing somebody is talking to us, or we can actually feel somebody is standing beside us, or we can feel something that is leading to more than stress level already. So we are not supposed to meet social psychologists or social counselors. Plus, I mean, it's better to go and meet clinical psychologists or psychiatrists who can prescribe medications. And once we are taking the medication, need a lot of rest. It will put us to sleep, and we need to sleep. All right. So I give the platform to the class to ask more questions, because Tania and me every day we discuss. We discuss mad topics. We discuss education topics. We discuss fun topics. All topics we discuss. Always Tania is the one come forward. She will start the conversation by commenting my status. then we will, it's kind of, she's really using a CBT towards me, you know. Not because she liked my status, but she's left to remind, hi doctor, I'm here, I'm still here for you, you know. Then I say, okay, there's one student, Tania, there, okay, now then we will start. So that's how she keep refreshing my memory that I have one student named that Tania, because I never seen her. She's back in Pakistan, everything through online email and only Webex and WhatsApp, and you know. So just to refresh the memory. It's a good treatment, in fact. She's giving a good treatment, you know, to me. That's good. All right. Okay. Now, I give it to the class to share, or you can raise your doubts. Okay, to Tania. Maybe she can help you. Go ahead. My undergraduate also can. Nur Fadila. All right. How to identify which technique or strategies in CBT we need to use to understand the level of severity client condition. Tania, you can see at the chat box.
Yes, ma'am. We can identify which technique used or which strategy we can use in CBT. Firstly, we make a list of symptoms of the patients, and then we take a pre-assessment rating and make an hierarchy of the patient symptoms, and then according to the symptoms of patients, we used different techniques of CBT. We identify techniques and strategies of CBT according to the symptoms of patient. Even you can also see that many people, when they are in education system, they are study as a student as a clinical psychology student or as a counselor student. In CBT, we read that this technique used with major depression, and it doesn't mean that we used all the techniques which we can use with depression. We used all the techniques of all depression patients. We used according to the severity level, and we use according to the symptoms of patients. So it's only depend on symptoms.
Okay,
Did you
Nur Fadila, or if you think she's not answered to your question yet, you can unmute yourself and ask her.
Assalamualaikum Tania. I would like to ask about how about the point the point view the point the perspective from counseling counselor, because I thought this is the clinical psychologist view, right?
yeah.
Yeah, so which part is counselor should do, because I'm new in this technique.
Sorry, I didn't get her question.
Doctor,
Can you
please.
All right, okay. Tanya, she's asking, your section is more to clinical psychology kind of thing. So which is the counseling part? All right, she wants to see
okay.
which is the counseling session. But Fadila, if you ask me,
Yeah.
counseling is kind of a technique, a tool as well. Okay, it's a
Okay.
treatment. Okay,
Okay.
it comes under psychology. Psychology is a very broad thing. So Tania is using the session itself called counseling session because she is a registered counselor. If
Okay.
solo clinical psychology, if she might give them a prescription or medication, ask them to go eat and come. When she's using
Okay.
the CBT to, check and balance, the chart, you see the chart, the session, that is called a
Yes.
silly counseling session. If I'm not wrong, maybe Tanya can add to what I explained.
Ma'am, actually, I work as a both as a counselor and as a therapist. Because I got certifications in both settings. My degree is basically in clinical psychology. That clears the license of my clinical psychologist. But I got some certifications and diplomas of counseling. So that's why I work both as a counselor and therapist. I work as a psychologist in hospital setting and in clinical setting from last 5 years. But I work as a counselor with Pakistan, among Pakistan mental health helpline. I work as a counselor from last 3 years because we give counseling to the patients of mild to moderate level, but we give counseling plus psychotherapies to moderate to severity level. So that's why we use these two things in our sessions. We can't use direct psychotherapy, and we can't use only counseling. So that's why.
Thank you, Tania.
Thank you.
Can you see, Fadila, how it works?
Uh-uh.
All right. You
Not
see,
very
the
clear, but
difference
I
between the
see.
different, yeah, once again, the difference between we and Tanya is she's a clinical psychologist. She is two in one. Okay. When she can start with the counseling session if she find that can you prescribe medications, Tanya? Are you eligible to prescribe medications?
No, ma'am. We give only psychotherapies and counseling. We can't.
Yeah. Okay. So they can deal with some therapeutic methods like hypnosis, all right?
Yeah, yeah.
But not fully on hypnosis, right,
Yes, ma'am.
Tanya?
Yes.
It's a part of the hypnotism, the activities. Because if we want to do hypnotism, we need to go a specific course for hypnotism. The one that I found way back, which is only for hypnotism, I need to spend 7 years
Hmm.
to in US, the one that we are seeing in Indonesia and India for 1 year and 2 years, that's a very short course learning of hypnotism. But if we really want to know about hypnotism, it takes a longer time to learn and to digest it. So the difference between we and Tanya is because she's a clinical psychologist, she can go and conduct certain therapeutic sessions compared to us. Okay, we only can do social services or social sciences or something related to social sciences. Our activities must be like in the sessions, like it include like activities like physical activities, is emotional, like mindfulness, like meditations and art therapy and what music therapy, um, what we call that perfume therapy, those kind of thing. To test, to use some machines, let's say, then it goes to the clinical psychologists. They
Ma'am,
use some
actually,
equipments. Am I right, Tanya?
yes, ma'am, you are right. Ma'am, actually, I'm very insane about my profession. So that's why many people confuse when they saw my CV and read my CV. Because I got many certifications and take trainings about hypnosis in Reiki therapy and addiction therapy in dialectical behavior therapy, and I used all these strategies with my different patients. If I deal drug addiction patients, then I used addiction therapy with them. If I deal a patient with different personality issues or personality disorders, then I use dialectical behavior therapy with him or her. So that's why it's also a confusing point, because in European countries they work only if a CBT practitioner sitting in a clinical area, um, he only used CBT with his or her patient. He didn't use any other techniques. And if an dialectical behavior therapist work, then he only used DBT. But in Pakistan and in India and in many other low income countries, the psychologists work on many fields of area, and they have many expertise in different areas of psychology.
All right. Thank you, Tania. So can you understand, Fatila, between we and Tania? There are two different things. I'm also psychology student. All right. But I'm not clinical psychology. I'm a social sciences psychology. Clinical psychology, the only university that really looking into it is UKM, University Kebangsaan Malaysia. And they really check our background. You know, they want a science stream student to do that. They want an art stream student to conduct it. And
Yes, ma'am.
even I going to pursue in that, I need to sit for many prerequisite papers before start the research or to get the title as clinical psychology. All right, carry on. I think one, Norida wanted to ask something.
Okay.
No, doctor, not yet. I'm thinking about it.
Okay, what therapists or counselor do if the client didn't do their homework? The effect to the session. What do you do, Tanya, when your client don't do any homework?
Ma'am, if client didn't complete homework assignments, then we try to complete in the session if he didn't. And it affect the sessions because we can't move on the next sessions before this.
Maybe that's for the first session. If okay,
Yeah,
I'll do that for in the first time when client don't complete. Second time, I'll ask the client to go back, finish
yeah,
the homework and come. The third time, it's a severe warning.
yeah, ma'am. Even we give some penalties to the patients. If he or she didn't complete his or her task, then we can't give our services to him or her.
Correct. This is why I teach all in a group session. You should have what guidelines, what should do and shouldn't do. First
Okay.
time, if you ignore the rules and regulation, well, we forgive. But the second time, we will give a warning. Third time, then we start with the we don't negative reinforcement. It's not punishment, negative reinforcement.
Yes, ma'am.
All right, okay. All right, Sharifa, what is the homework you always give to the patient with depression in CBT to help them to get out of their, I mean, this kind of cycle? Sharifa, it's always depend on the client. Not when you are using CPT, you must use the A technique or B technique. That's not actually right. Um, it depends on the client. Depression also, it has the level of depression. Okay, so however, in Tania's case, maybe Tania can explain on this.
Ma'am, we always, in terms of always, we always give a DTR chart to every depression patient. Doesn't matter he or she has what type of severity level, but we give this DTR chart for their understanding about negative automatic thoughts and about the understanding about their vicious cycle. But despite of DBT, DTR chart, sorry, we psychoeducate very well to the patient when we used vicious cycle in the session. So here is no need to give any other things for their understanding, because I have not dealing any patient who didn't understand my point about the vicious cycle or about his or her disease. If we psychoeducate well, then here is no need to give any task for the vicious cycle.
All right. Thank you, Tanya. Any other question? My undergraduate, faham ke? Tak faham English, you tell me, I'll translate to her.
I have a question.
Please go ahead. Who is this? Introduce your name.
Asma. I'm Asma.
All right.
Um, about the homework, like if the client like doesn't do the homework like for one time, then maybe we try to do it like you mentioned just now. But then like even after like a few sessions, they still don't do the homework. Does that mean like CBT is not for them or something like that? Like, do you continue on to do CBT if that's the case?
Tanya?
Yes, ma'am, we can do if the client has no need to take CBT, then we used counseling strategies with that client. So as a homework assignment, we didn't give any type of worksheets. We did some task about to maintain his self hygiene, about to maintain his a daily healthy routine, and many other tasks. So here is no need to take any worksheet or any homework assignment in written form.
But then if you ask me, if that one client doesn't want to do the homework, then something wrong with the client. It is
Yeah.
not with my session or my theory actually. So
Okay.
we can always ask the client, or we can give the choice to the client. If he or she doesn't like, if she feel like wanted to quit the session, she can quit.
Hmm.
I'm not going to jump from CBT to RABT.
Ma'am, we can also refer these type of patients. I deal a patient in last week. He has some marital issues, and he has also some sexual thoughts, and he still resist in this thing that I can't complete any type of homework assignment. So
Mm.
I referred him to another therapist.
Yes, true. We refer to another therapist. It is not, always remember, it is not the session. It is not us.
Hmm.
It's the client itself. Okay?
Okay, thank
Next
you.
question. All right, next question.
Hi, Dr. Jaya here.
Yes, correct. Go ahead, Jaya.
Okay, good morning, Tania.
Good morning.
Sorry. And it's good to see.
Jaya, why are you like radio, you know, radio, what we call that, anchor only. Suddenly, all of a sudden.
Actually, kat sekolah saya memang MC,
Anchor.
so yes, MC for all the events. So normally they will call me MC. So maybe that tone saya macam tu lah, doctor.
Okay, carry on then.
Okay, I'd seen the video and it's good, but I can't hear clearly. There are some noise and big of
Hmm.
sound. So sorry if I missed it. The main issues that I saw with the client is marital issues, right? With
Yeah.
pregnancy, with problem with her husband, and had some fight with her husband and kick out from the house. Also, did she separated with her husband? I mean divorce? No, no, right?
No, no.
No, but her parents ask her to
Hmm.
go for that, but
Yeah.
she don't want to divorce her
Yes.
husband. Am I right?
Yes, yes.
Okay, what I saw in this video is like he focus on how to solve, how to what to say, how to help her to come out from her problem, like a mental health
Mm.
problem. Did you focus on marriage problems, or like how to solve her
Yeah,
issues in her problem, marriage problem?
yeah,
Did you help her?
yeah. We only guide the patient to solve their problems. We didn't give some solutions to the patients directly to the patients, because if we give some solutions about the problem, then patient feel dependence on the therapist. If patients show dependency on the therapist. And I shared only first two sessions videos with all of you. So that's why here is your question, because in the next sessions we use some other techniques, and then we move on marital counseling and give some tasks about the problem, and we use problem solving method in this scenario with the patient. Problem solving method is the basic technique of CBT. We used with the patient, and then she finally take her decisions about her divorce, and then we guide according to her decision. We can't forces, or we can't imply our own opinion and decisions on the client, because it shows biasness. It's all up to you, up to client.
Okay, thank you.
Thank you.
Next question. My UG, why are you so silent? Are you all there or not? UG, at least 3 questions. UG. Auni?
Doktor,
Ya saya. Silakan.
kalau tanya dalam bahasa Melayu dah tak apa ke doktor?
Okay, you ask, I'll translate.
Okey, ini berdasarkan video lah, video yang telah ditonton. Tapi yang saya tonton tu dalam video satu dengan video dua macam tu je lah. Tapi saya tak pasti sebabkan video dah bahasa Inggeris kan. Cuma ada yang doktor saya ada yang waktu sesi tu dia beritahu ubat tidak diberikan kepada pasien kan. Maksudnya buat rawatan secara bukan memberi ubat lah. Okey, soalan saya, seandainya pasien tersebut orang kata dia tak dapat kawal diri dia, adakah doktor akan bagi ubat kepada pasien tersebut?
Alright.
Ataupun ubat tak akan diberikan?
Kan saya dah kata yang ni bukan di bawah kita punya bidang, kita akan refer pada psychiatric. Alright. Anyway, Tania, her question is if the client has severe, let's say, depression, and needs prescribe some medications. What are we going to do? Can we prescribe, or we can give it to, what we supposed to, what is our next action? Well, I think I've already explained this, and Tania also already explained this, that both of us, we can't prescribe any medications. So we refer to the psychiatric, okay? And then they will do the assessment all over again. It's same like how you go to private hospital, then where you go to government hospital, and then you go to private hospital, or government hospital to another government hospital. Then they will start doing the entire procedure all over again, right? Same thing here also. The clinical psychologist also, the psychiatric also, they will do the assessment all over again, and they'll come up with their own decision to what sort of pills supposed to give. As I told you, seperti mana yang telah dibincangkan, depression can divide into many categories. Schizophrenia, it has a different drugs. Multiple personality, they have a different drugs. Split personality, they have a different drugs. All right. So
Ma'am, actually, I deal patient with major depressive disorders recently, and she has severe level of depression, and she here is need to take some medicine. So I refer her a psychiatrist in my hospital, and she take medications for 2 weeks, and after that she come to me for counseling and therapy. We can't give counseling and therapy if patients on medication, because she is not in that condition. I used any type of therapy or counseling with her. So that's why. Ma'am, here is some questions in the chat box.
Yeah, carry on. How?
My question is automatic negative thoughts that can contribute to and exacerbate difficulties, depression, and emotional anxiety. How CBT can change the client. CBT can change the client in a positive way very effectively if we used strategies of CBT according to the symptoms of patient. So then it will work. Is there time required for each sessions? If required, how much time needed for each session? Yeah, we give one individual sessions in 45 minutes, and according to the therapeutic guidelines, the clinical session with the patient is about 45 minutes to 1 hour. Uh, is there Okay, how do we know the effectiveness in giving CBT? You can know the effectiveness when you used pre and post assessment rating of the patient's symptoms. You take some assessment pre-assessment rating in your first and second sessions, and then you give some counseling and give some therapies and use some strategies with patient, and at the end of the sessions, in the last sessions, you again take some ratings of your patient symptoms, and then you easily compare the effectiveness and pre and post assessment ratings. Such as my one of my patient of conversion disorder, she took she took 4 sessions for her problem. In first sessions, she said she has sadness, and she has anger issues, and she feel anxiety on 1 to 10 Likert scale. On 9 and 10, she give 9 and 10 rating on visual analog or Likert scale, 1 to 10 rating scale, and in first session. And in the last session, she is very happy and she's very excited. Even she brings some sweets for me with her husband, and she gave rating 2 and 1 on her rating scales after assessment in last sessions.
That's good. Right. How do we know the effectiveness in giving CBT?
Yeah.
Yeah, sometimes not only CBT, any other treatment also.
Yes.
How your client appreciate, Like for example, my undergraduates here, we have been doing some programs since like June. And when our programs get highlighted, came in the newspaper, and then plus in email, and everybody congratulated them and praised them. They felt that, wow, okay, I've done something. But before that, when I gave them homework to do, I asked them to do this, do that, then they found that doing a project is not easy, and always get scolding from Dr. Sarala, But when you listen to me and how you know it is successful when people congratulate it, people praise you. So that shows that effectiveness of what we have done. Or of course they will have, downs and ups. That's normal. We can't be expecting 100% perfect. But overall, we'll say overall, like what Tania said, when she got a sweets or chocolate for her, then it's kind of, yeah, effective. I'm teaching you all, when you go through the subject, when you pass the exam, then it's effective. My teaching is effective.
Ma'am, even I shared two videos with you, and in the first video, patient feel very depressed, and in the second video, she is very excited and she is very motivated to solve her problems and discuss with me. So here is also you can see the effectiveness. You can check the effectiveness according to the behavior of your patient, according to the response of your patient.
Okay.
Hi, doctor. I got questions.
Yeah.
Hi. My name is Azlin. I'm an undergraduate student. So, I was wondering because we will be inshallah, one day we will be the school counselors, right? So, we are dealing with the students and teens. I just want to know that is CBT different when used in children and used in adult? That's my questions.
Ma'am, can you repeat this question?
Yeah, okay. She's asking CBT used for which group of age group of people? Again, in the class, I've told you, theory doesn't spread any demographic factor doesn't impact any theory, or any problem is not fixed to any theory. If I'm a psychoanalysis person, if I'm good in my conducts, I can use psychoanalysis to anybody, any gender, any age group, any religion, and any issues. Right? That's from my perspective. I don't divide, like for children is reality, for teenagers is CBT, and for elderly people is psychoanalysis. I don't divide. Some of them they do, but I don't find any difference in that. I've conducted my psychoanalysis to all age groups, all genders, and all ethnic groups. However, maybe from Tania's industrial practice, maybe we can hear something from Tania.
Yeah, ma'am, you are absolutely right. We used CBT with all ages groups and with all gender groups because in children we use CBT with the conversion disorder, PTSD, schizophrenia, OCD, major depression. Uh, Many children and many adults suffer from these disorders. When a child come with major depression and a child come with mood disorders, then we use CBT with the child. So here is no any specific age criteria that you can use this age group or not. Even we used CBT with the age of 7 years with a 7 years child who has conduct disorder. So even we can use this we can use this with a male patient 60-year age, and we use CBT. So from 7 years to 60 years, it's depend on the disorder. If you want to ask about the age group of special children, so we can't use with special children CBT. We use behavior therapy with those children. But with other children with other psychological issues who have not any disability or who are not special child, then we use CBT. We can.
Okay, did she answer your question?
Thank you.
All right, okay. Any other question?
Dr. Norida here. Hi,
Please.
Tania.
Hi.
I'm not so good at any of the theory yet, but in CBT, how to start exploration of client problem by using this technique CBT? Like, what kind of suitable question to be asked in the beginning?
We can use some assessment tool with the patient to explore some thoughts. We can use both projective test and objective test. Like we used if we deal major depressive disorder, we used back depression inventory for a clear diagnosis and to check the severity level. And if a patient didn't tell us more about herself, then we used projective tests such as house tree person, such as good enough Horace drawing test. So we used assessment tool to explore the different psychological factors of the client. And we also we also take information from the families of the patient. Families also reported many things about the patient.
Okay.
Okay, doctor, sorry if I want to ask more. That one is in the clinical setting lah, doctor, right?
Mm-mm.
So ada macam like in inventory and so on. So like us in social setting macam tu, doctor, is more simple or macam mana?
No, whatever Tania is doing, that's what we will do also.
Yeah.
We will use all the inventory also, doctor.
Yes, yes, yes. We are
Uh,
supposed to use inventories. We are not supposed to prescribe medications, pills only. Pills, and also some of us is very good selling some MLM product, right? Like Amway product and to boost this that. Sometimes we don't actually we are not supposed to encourage them to buy all those stuff and eat. We
Ma'am,
give
yeah.
carry on, Tania.
Sorry, ma'am, you can carry on.
We need to ask them to explore, and they get checked and see and what does the doctor suggest. Yeah, I know sometimes when they lack of calcium, we can suggest there are a few supplements in the town that they can take it. We try to be too good, but it's not in our job scope, so be careful not to do that. Nothing wrong doing it, but we are not supposed to do. That's it. It's not in our job scope. Okay. If tomorrow the medicine or the supplement gives a negative reaction for them, then we are in trouble.
Ma'am, in that point, we give some medical adherence to patient and family.
Mm-hmm.
So, but we can't prescribe medications.
Yeah.
We know about medicines. We know about the uses and side effects of medicines because we need to give some psycho educations about the medication adherence, but we can't prescribe.
Yes. True. We can give a referral letter to go and see the suitable people or a doctor to get checked up and everything. That's fine. But we cannot suggest this product, that product.
Yeah. It's ethically wrong because many therapists suggest and recommend, but it's ethically wrong and it's a crime.
Yeah, moreover, we have some MLM businesses, I don't know whether they have it in Pakistan or not. Here we have some boost, coffee that can boost up or your immune system. Mangosteen coffee. What some more? Mangosteen, Nestle product, So we want to suggest for them, and maybe also because we are one of the member, we want to sell our product. Remember, we are not supposed to. Not only being as a counselor, your lecturer. If I'm going to promote you, buy MOA calcium. That's very wrong. You can complain against me. We had a memorandum 2 months ago, a circular to all the to the university. That means all staff can actually, it's applied to all staff, especially academician. Academicians are not supposed to, I mean, sell their product. Product means if I'm outside from you, I mean, it's how to say, yeah, you become a member of some product, like as I told you, this mangosteen coffee. So you want to sell. You can, in the class, you can suggest and talk about it. Then the student find that, oh, if I buy, I'll get A. To please you, they also buy and drink. After they drink, not complete even 1 month, they say, hey, I got so fair because drinking this coffee. Bullshit. My God. No treatment will come. No, you can't see the effectiveness in 1 week, actually. At least it will take 3 months minimum. So be careful, doing all this. It's ethically wrong. Okay? Any other question? Any other question?
Doctor, one more question from Jaya.
Please.
Okay, Tanya, I noticed that when you started the conversation with the client, you asked the date with the client. What day is today? Is there any reason behind that?
It's really important because we check the orientation of the client. We ask about the place, the setting, the time and date, to check the orientation. If client have a poor or bad orientation, it indicates a psychotic feature.
Okay. And one more question. I couldn't see any informed consent there. Uh, is there any reason why?
You mean informed consent form signed?
Yeah, doctor.
She should have signed in the first session or earlier. Maybe you didn't see in the video. That is all initial stage. This is session stage. This what? How this is what session, Tania? First session or second session or third session?
Ma'am, first session, in first session.
She should have done it before the client enter or something like that.
Oh, okay, doctor.
Yeah. My undergraduate and also SINTOK. SINTOK. Very quiet. Kalau ni boleh tanya dalam bahasa Malaysia, I will translate. Sir Thiessen can. Mr. Thiessen can now. Can ask. I unpause you.
Okay. You released the Kraken now, Doctor.
Yeah.
Okay. Good day, Tanya. In fact, I was so happy I saw all your videos because you rarely get opportunities to see a whole video like this. Normally, we see other, movies. We never see a good video on counseling. And in fact, one of the questions was I was a bit happy with that. You did a space and time orientation, as Jaya picked up, to check on the mind and the state of the mind of your client. That's very good. I mean, not really many of us do that. And the first video also, I noticed that you have started giving homework. I was quite happy because I always wanted to know why some people don't give homework in first session. Is it because they wait until second session to come back to give homework? But yours is first session, you give homework. But I was so quite happy with the first video. A lot of things that clarified a lot of my answers in my mind. And then on the second video, you did the hypnosis. I think that was some part of I'm not sure whether you're teaching her self-hypnosis or are you actually doing a hypnosis on her, because lying on the bed, the video overlaps, so I can't see much about it.
Okay.
Answer me that later. Then I got one more last question for you, only.
Okay.
Self-hypnosis or you're doing hypnosis on her?
I don't understand the last question, but I could answer the
The
first
lady was
question.
sleeping on the bed, and then you're reading something out to her. Am I right? The second
Ah,
video. And is that a self-hypnosis? You're teaching her how to own self-hypnosis, or are you doing hypnosis on her?
okay. That is not hypnosis.
Ah.
That is only a small strategy of hypnosis therapy. So,
Ah.
okay, only for to clear the rationale about the negative automatic thoughts to the patient, only for the purpose of psychoeducation
All right.
about her disease and about her negative automatic thoughts and it is.
All right.
So that is not hypnosis, and patient use this strategy on her own self. She can
Okay.
use.
Okay. But that's very good. All right. The last question, so just know as to save your time. You mentioned about detachment, mindfulness as a
Yeah.
therapy is to be very effective. But I may be wrong. When you talk about detachment and mindfulness, there are two different sections of it. One is detachment, and the other one is mindfulness. These two actually are they not correlated to psychoanalysis?
Yeah, you are right. Many people confuse and mix this concept. Mindfulness and detached mindfulness both are different things. And detachment and mindfulness, these both are two different things. And only detached mindfulness, total word, total term is a CBT therapy. These three are different domains. Detached mindfulness, detached and mindfulness, detachment and mindfulness. These are three groups, three different domains.
Okay. All right. Thank you very much.
Thank
I'm
you.
still reading on the part of detachment mindfulness, and I always thought that it's a psychoanalysis approach to look at the change to the inner thoughts and feelings. So it's okay. Thanks for the clarification. And definitely, I know Dr. Salah said, he said you need to read more, and definitely I need to read more on that. Thank you very much.
Thank you.
Thank you, doctor. That's all on my part.
All right. Any other question? Any other question? All right.
Doctor, sorry.
Silakan.
Okay, I'm Rosadi from PG student from UUMKL. So
All right.
here I have two questions to ask Tania. Okay, the first question is in the first session, I noticed that you do MSE to the patient, right?
Yeah.
Okay, what is the abnormal behavior of finding that allowed the CBT sessions to continue and not to continue? That's the first question. And
Okay.
my second question is why hypnosis cannot be done to patients who have chronic insomnia?
Okay. First question. Actually, I want to the same question from all the class students. But I answered this question. Um, we uh, we face and we judge the behavior of the client, and then we can't say it's abnormal behavior because she is come with major depressive disorders, and patients with major depressive disorders didn't show any type of abnormality or abnormal behavior. They basically have some negative thoughts, negative feelings, and negative emotions. If she is come with conversion disorder, if she come with schizophrenia and other psychotic disorders, then we can observe her abnormal behavior. But if you want to ask about some problems or issues or symptoms which we observe, and we want to discuss and guide her properly, then I mentioned in that videos also, when we are setting our goals, we write her all symptoms, and then we setting goals of our sessions, and then we taking pre-assessment ratings. These are the main issues, and after some sessions we can move on her marital issue. So these are the basic some issues of that client. And for your second question, we use hypnosis with the chronic patient. We can use. I don't know who is tell you we can't. We can use this.
Yeah, I agree with Tania. Actually, can.
Because I'm read some articles that notice that hypnosis cannot be done to patient who have chronic insomnia. So I'm wondering why.
Okay, chronic insomnia. Yeah.
Yeah.
We can't use. We can't use. Sorry.
Okay. Thank you, Tania.
I thought about depression. Sorry. We can't use with chronic insomnia because in hypnosis, we give patients a trance situation, and that's why already if patient has some insomnia issues, then hypnosis affects very badly on her condition, his or her condition. Firstly, the patient need to take some therapeutic and medicational treatment about insomnia, and then we can use hypnosis.
Okay, Tania, thank you so much.
Thank you. Even I also want to add some things. Chronic insomnia also and mostly show those patients who are 2 years who having 2 years major depression episodes. The patients who have major depressive episodes from 2 years, they have also chronic insomnia. Firstly, we use some psychoeducation and relaxation treatment, and then we use laughter therapy. And after that, we use CBT, and then we can use hypnosis.
All right. Good.
Doctor, got question in chat box, Doctor, from Nasruddin.
If you don't mind sharing your experience with psychotic patients, do you have experienced psychotic patient, Tania?
Yeah, ma'am, I have 1 year experience in mental hospital when I doing my placement or house job, you can say. So I work with many psychotic patients with females and males, and also I share my portfolio with you, and you can share with these students. It will really helpful for them to understanding about the psychotic disorders and their treatment. Even I completed some courses. I done some courses with those patients. I used some beautician courses. I used some gym exercises courses and computer courses. I give training to the patients for their independency and for their confidentiality and for better understanding to those patients who are in rehabilitation centers of mental hospital. They can understand my instructions and they can understand many of things. And I work both with male and female. And if we talk about CBT, we used cognitive restructuring with psychotic patients, but we can't use therapy with patient. If a psychotic patient has moderate to severe level of psychosis, we can't use any type of therapy with psychotic patients.
Is that clear? Is that clear?
Doctor, thank you, Tania, Doctor.
Thank you.
Okay.
Ma'am, I have a free camp and
All right. Okay. Okay.
at 9 a.m. So
All right. Thank you so much.
thank you.
If we have more discussion on this, maybe we can have it. Tania will be here most probably next year. or by end of December. Hope to see her in Malaysia. So, all right. Have a nice day. Thank you so much for the wonderful sharing.
Thank